Hello everyone, this is Dr. Nakula Mehta from Aspire MDS. In this lecture, we will discuss about all about dental implants. We will be covering about the types of bones, the types of implants, the osseointegration process, and about various novel procedures in implantology, about the sinus lift protocols, and the reason of implant failure and the treatment of implant failure. So let's start about what is an implant. Any body part which is replaced with a prosthetic component anywhere in the body is an implant. But when I talk about a dental implant, it is a substance that is placed into the jaw with the support of crown or fixed or a removable denture is called as the dental implant. It can be of various types. What we basically know is the subperiosteal implant, which is lying on the bone. It is called as the epiosteal implant also. Then we talk about the endosteal implants, which only crosses through one cortical plate, and hence it's called an endosteal dental implant. And the transosteal dental implants, which crosses through both the plates of the bone, and hence it's called as the transosseous implants. Now when I talk about the types of endosteal implants, it can be in a form of a root, which is seen like this, the normal what we use. It comes as a blade form also, which is also called as the platform endosteal implant. Also this is the ramus frame, which is used for the coverage of whole mandible. Then what we use in subperiosteal implants, they can be classified as the unilateral one. It can be a complete denture which has a ball and socket joint just as what we use in the overdenture, and also it can be used as a circumferential subperiosteal implants. So these are the types of endosteal implants and the subperiosteal implants. Whereas the transosseous dental implants, they are available in a staple form, single pin form, or a multi-pin form. Now this was the classification based on the type of implants. Now when we classify it based on the materials which is used, it can be classified as made up of metallic implants, which can be titanium alloy, cobalt chromium alloy, and based on non-metallic it can be ceramic and carbon. Now based on the reaction of the bone, it can be bioactive implants and it can be bioinert implants. Whereas depending on the treatment options, it can be divided as FP and the RP1s. FP1s are the fixed prosthetic part and the RP1 are the removable prosthetic part, that is just what we can see in the overdenture, that is implant supported overdenture. So let's talk about the parts of a dental implant. When we see the natural tooth, it has a difference that the PDL is lying, periodontal ligament is lying by the bone and which acts as a cushion. But when we see the osseointegration of bone and the implant, there is no PDL which is present. So this is the crown part which is made up. This is the abutment which is placed during the second stage surgery in a two-stage implant. This is the whole implant which is an active implant, as you can see the threads, and this is the bone where it has been osseointegrated. So let's talk into the details how the treatment planning consideration on the implant is done. So basically what we see is about the bone density, about the available bone, how much it is present, and the spacing which is required, that is from any natural tooth, or we can say from the nearby vital structures. So let's get into the normal anatomy of a bone. When we talk about, this is the normal bone with how it is seen. It consists of a ostium, which is the basic unit of a bone, and it is lined by what we see. It consists of canaliculi and the lamella. The lacunae are present, which are the cavity like structures. The ostium, that is the osteon, that is the again cells of the dental on that bone, that is the alveolar bone. And when we talk about, these are the Haversian canals and the Walkman's canals, which are used for the nutrient supply of the bone part. So this is how the normal cortical bone looks like, and it can be then classified as D1, D2, D3 and D4 bone depending on the density and the placement or the position where it is present. Also now inculcation of a D5 bone has been given. D1 bone is the densest bone, which is seen mainly in the anterior mandible in the lingual cortex. And D2 bone, when we talk about, it has a partially edentulous anterior, which is mainly made up of cortical bone, but it is cancellous to an extent in the center. It is seen mainly in the posterior mandibular region. When we talk about the D3 bone, it is mainly seen in the maxilla, which is mainly consisting of what you can see over here is the cancellous bone in the between. It is porous and it is present in some parts of the posterior mandible and the anterior maxilla. But when we talk about this D4 bone, it is the softest of all and it is mainly seen in the posterior maxillary region. Now this D1, D2, D3 and D4 bones can be classified based on the Hounsfield unit to which they can withstand. So D1 has a density which can withstand of more than 1250 Hounsfield units. D2 can bear a pressure of about 850 to 1250 Hounsfield units. For D3 it's 350 to 850 Hounsfield units. For D4 it's 150 to 350 Hounsfield units, whereas D5, now this D5 is the bone which is found in the recently extracted tooth, that is the what we can say as the extraction socket. Here the D5 bone consists of the Hounsfield units which are less than 150 Hounsfield units. So these are the factors how the bone density matters in the planning of a dental implant. Now when I talk about this osseointegration, it is the integration of the bone and the implant. How does it start? When we talk about the success rate of an implant, when we see for 5 years it is about 90%, for 10 years it is about 85%. So this success rate depends on how better the osseointegration of implants with the bone has been occurred. So when we talk about the osseointegration, during the day 1, when the implant is placed in, just after that if we see the threads, they are in contact with the surrounding bone and there is a coagulum which surrounds the implant. By the day 4, when we see the coagulum is replaced by the tissue and the fibroblast cell-like cells are present, also the inflammatory cells are present. When we see the osseointegration by day 7, you can see provisional matrix is formed and a new open bone is present. By 2 weeks, you can see intense new bone formation and increased connective tissue near the implants. When we see the implant site after the placement, after 1 month, that is the 4 week, you can see a woven bone which is present and you can see parallel fiber lamellar bone. Apart from this, when we see after 8 weeks, that 8 to 12 weeks, that is about 2 to 3 months, what you can see a mature bone which is growing and hence a mature being surrounding the implant is seen. So that can be called as a osseointegration. So basically this osseointegration takes about 3 months to occur minimum. Now this is the normal dental unit what has been shown, the implant unit, which is also called as physiodispenser unit. It consists of a foot controller. It consists of a handpiece. This is how the handpiece is seen and this is the controlling panel. It consists of torque, it consists of RPMs and it shows at what unit this has been revolving. The implant, when it is placed, it can be a motor driven implant or it can be a hand driven implant, but for drilling what we use is the normal physiodispenser unit. Now when we talk about the implant kit, it can be a simple, that is a beginner's implant kit, or it can be an advanced implant kit which is shown over here. Now when we talk about this part of a dental implant kit, this is the ratchet driver what we see and these are the drills. These two things are the parallel pins which is used to see the parallelism of implants when we are placing the multiple implants. The first drill what we drill during the implant placement is called as the pilot drill, which is about 2 mm, which is shown over here. And for the placement or marking in the bone, the first and foremost sharp pin what we use is called as the lance drill. So we start with a lance drill, Then we go for the pilot drill, and beginning from this pilot drill, based on different implant systems, the drilling size can be different up till the width of the dental implants. So we should remember that the kit, when it is used, it can be the diameter. Suppose if you want to go for 4.3 mm diameter or 4.8 mm diameter of implant, we should drill the implant less than one size of the implant what we are planning. Suppose we want to go for a placing implant of 4.8 mm, we will drill up to the size of 4.3 mm, and the last drill would be the implant itself, though it's an hand driven implant or a motor driven implant. So when we talk about the criteria for implant success, it can be based on the unattached implant that is immobile when tested clinically. The radiograph should not show any radiolucency. The bone loss is less than 0.2 mm annually just after the first year placement of the implant. Later it can be less than 0.1 mm, that is the crestal bone loss. If the crestal bone loss is more than 1.1 mm per year, it could be considered as an implant failure. There should be any absence of mobility, and an average radiographic marginal bone loss of less than 1.5 mm during the first year of function and less than 0.2 mm annually should be there after. The absence of pain and paresthesia also shows that the success of implant is there. Now when we talk about the implant surface procedures, there are various procedures for the modification to enable the dental implants and making it suitable for implantation and osseointegration. The three procedures what we talked about generally are the passivation, anodization and the ion implantation. When I talk about passivation, it refers to the enhancement of the oxide layer to prevent the release of metallic ions as a result of surface breakdown. This also enhances the biocompatibility of the materials performed through the immersion of 40% nitric acid. It is minimally increasing the oxide layer thickness on the implant. Now when I talk about anodization, it is an electric current which is passed through the metal and results in a thicker oxide layer on the implant, which is more beneficial for enhancing the corrosion resistance in titanium implants. When I talk about ion implantation, it is bombarding the surface of the implant with high energy ions up to the surface depth of about 0.1 micrometer. This procedure is claimed to increase the corrosion resistance of metal through the formation of a titanium and tin surface layer. Okay, and when we talk about the types of implants, it can be either a one-stage implant or a two-stage implant. In a one-stage implant, we place the implant in the very first sitting and the abutment is loaded along with during the first surgery also. So during the second step, we only want to go for the prosthetic part, not to expose the surgical site. But when I talk about a two-stage implant system, only the implant placement is done during the first stage surgery, and during the second stage surgery we go for opening of the exposure of the implant, and then abutment placement is done. The gingival collar is led to form, and once the abutment has been placed, the impression is taken and the prosthesis is given. So two-stage implants basically needs surgeries twice. Now when I talk about the incision of implants, there are two types of incisions mainly which are used. One is the mid-crestal incision, that is along the midline of the edentulous part, and one is the remote incisions which is far from the surgical site. We can open the or reflect the entire flap and place the implant. The sutures which are generally taken are the direct loop sutures for the implant after the implant placement. Now what if the sinus is very much in approximation to the bone in the maxillary sinus or maxillary molar region? We go for a procedure that is an indirect sinus lift or a direct sinus lift. Now when I talk about the indirect sinus lift, it is used when the bone height is at least 5 to 6 mm and the direct technique can be used if the height is less than this also. So when I talk about the indirect sinus lift, this is the indirect sinus lift kit. What you can see during the implant placement only, with the help of this kit, the sinus lining has been pushed for about 2 to 3 mm, and hence the sinus goes a bit up. Bone grafting has been done over here, and the implant is placed during the surgery itself. But when I talk about this direct sinus lift, it is more invasive, it is more technique sensitive. A window has been created over here to lift the sinus. The bone grafting material has been placed, and the bone formation is left to occur for about 6 months. After the direct sinus lift procedure, we wait for about 6 months, then we place the implant once the bone has been matured. Now what we talk about the implant stability, it can be a primary implant stability, and there is a thing called as secondary implant stability. Primary implant stability is the stability which is gained by the implant during the placement of the implant itself, whereas secondary implant stability, it is assessed after the osseointegration has occurred or at any time later after the placement of prosthesis even. Now when I talk about the methods to assess implant stability, it can be invasive methods and non-invasive methods. The invasive methods that are used in an open site, so it is called as invasive method. They can be surgeon's perception, insertion torque method, or the seating torque method, as well as the reverse torque method, which are used directly with the help of implant ratchet while placement of an implant. The non-invasive methods can be radiographs, percussion testing, impact hammer method, the perio test, implant mobility checker, and the RFA analysis, that is the radio frequency analysis. Now this is the device which is called as perio test. Here when we see, here the inverse digits are used. You should remember that the readings, if it is less than, in the negative side, that is -820, it suggests good osseointegration, implant can be loaded. But when I talk about if the values are +1 to +9, it is having clinical examination is required, and most of the cases loading is not possible. While if the values are +10 to +50, the osseointegration is not sufficient and the implant should not be loaded. When I talk about the radio frequency analysis, the ISQ scale, that is the implant stability quotient scale in the radio frequency analysis, range from 1 to 100, and it corresponds the radio resonance frequency in a close to a linear way. Now when I talk about basal implants, these are also called as the remote implants, because also they are named as orthopedic implants, because they took the support from the remote bones which are present. It takes the support from zygomatic bone, or you can say the cortical bone in the nearby areas. These are longer than the normal bone implants. This is how a basal implant is seen. It can be available as a disc form or a plate form. In the anterior zone, it can be used as a disc of diameter of about 9 to 10 mm, whereas the crestal disc is about 7 mm in diameter. In the posterior implants, it can be used with a disc of about 9 to 10 mm and with a shaft of about 10 to 13.5 mm in length. Now what are the unique things about this basal implants? The basal implants have spatial form and shape which allows them to place even in areas where the bone is deficient. Even the immediate loading can be done with the help of these basal implants. It saves the time and saves the number of visits and the secondary surgery also. It avoids multiple injections and multiple surgical procedures. It avoids complicated and expensive time-consuming sinus lift procedures as well. Now what are the complications what are generally seen in basal implants? The two types of complications are seen, that is the functional load osteolysis and the infection. The masticatory forces, they are transmitted by the basal implants to the anosal location that creates a micro cracks in the cortical bone, and they can be repaired by formation of secondary osteons, and hence the process is called as remodeling, which is mainly seen in the basal implants. Also, the chances of infection from the secondary side is very much possible in case of basal implants. Now, when we talk about implant failure and management, implant failure, when we see, it can be a first intense when we can see the various factors like a mobility, crestal bone loss, pain or paresthesia nearby the implant, or whatever function we need it. If it is not reached, we can say that the implant has failed. It has two terminologies like ailing implant and a failing implant. Ailing implant is the implant which we can see a radiographic bone loss without any inflammatory signs or mobility. But when we talk about failing implant, we can see a definite bone loss and increasing clinical probing depth, bleeding on probing and suppuration. Now, what are the reason of this implant failure? It can be systemic factors like bone diseases in patients of osteoporosis and osteomalacia, autoimmune disease like Sjogren syndrome and SLE. In case of pregnancy, this should be avoided, implant placement, endocrine disorders like diabetes mellitus, and serious disorders like myocardial infarction and severe hypertension. Patient related factors like smoking, when we see that the patient who is smoking, the implant failure rate is increasing by 3 times because of more bone loss. Even in patient with poor oral hygiene and bruxism, implant failure rate is increasing. The surgical mishaps for implant failure can be improper healing, overheating and overpressure while placing the implant, lack of stability of implant. Even there is severe angulation, it may cause implant failure. The restorative failures can be pyre abutments if it is used, and excessive, what we can say, pressure that can be due to the cantilever which has been placed along with the implants. Also, the implant should never be connected in a bridge with the help of a natural tooth. There should be only implant connection. Now, the clinical signs of early infection can be swelling, fistula, suppuration, and osteomyelitis can also be seen initially. When we talk about the pain is also present and the clinically mobility in the implant may be seen. The late signs of implant failure can be hyperplastic soft tissues, swelling, pistulation nearby the area, and changes in the color of peri-implant mucosa. The treatment of failing implant, it can be surgical intervention with a mechanical debridement and antimicrobial therapy, and if needed, we can go for guided bone regeneration. The failed implant should be replaced once it has been taken out. The bone grafting should be done. We should wait for the new bone to form in that area, and then the new placement of the implant should be done. Now, these are the two concepts which we should know about implantology. One is the platform switching. Previously, what happened? We used to take the implant and the abutment of the same diameter, and hence there was the uniform diameter of the whole implant, and the continuation of the abutment was seen. But what happened here? Gradually bone loss was seen. Accidentally, one of the dentists once used a smaller sized abutment than the normal implant what was to be used. What they noticed is the bone was grown over here in the crestal part, and it imparted more stability, and the crestal bone loss was less. So this was the principle which was then introduced, and this is called as the platform switching, where the abutment is smaller than the normal implant diameter what has been used. So the platform over here has been switched. It is called as the platform switching, whereas normally if we use the same abutment as the implant, it is called as platform matching. Now, talking about this jumping distance, when we go for a direct, that is the immediate implant placement after the extraction, when we can see a socket which is irregular and more in diameter than the normal implant. Now when the implant is placed in such socket, if the socket is remaining empty by less than 1.5 mm, it should not be grafted. But if the place between the implant and the cortical bone or the extraction socket border, if it is more than 1.5 mm, you should go for grafting and if needed PRF. So this would lead to more stability of the implant, and this distance is called as the jumping distance. If the jumping distance is more than 1.5 mm, you should go for grafting in that extraction socket part. So that's all for implantology. Thank you everyone.